There are a set of common toxicities that occur in PI3 kinase inhibitors, and some that are specific to the individual inhibitors. We know from knockout mouse models that if you inhibit the delta isoform, that this puts at risk the consequence of having a colitis. It's an autoimmune colitis. And so that's an on-target toxicity that generally occurs late after someone's been on a PI3 kinase inhibitor. There are other toxicities that are also seen. For instance, with duvelisib and idelalisib, we commonly see elevation in liver function tests. The absolute incidence of these abnormalities varies from one drug to the next, but we can see in the first 10 weeks or so an elevation of liver function tests. They generally get better after the drug has been held and then reinstituted. I think across this class of drugs we are concerned about infectious complications, and so certainly physicians need to be aware of these and be sure to monitor patients for that. Now there's some unique adverse events that occur with copanlisib. Copanlisib, because it inhibits the alpha isoform of the PI3K, you can have transient hyperglycemia as well as transient hypertension. In reality, this is generally well tolerated for most patients with not much more added monitoring that needs to be done. These different drugs lend themselves to different patient populations. You might consider certainly an oral medication is more convenient for most patients, but there are some times when an IV medication is better. You can consider patients, for instance, if there's a compliance issue, that might be better. There are other reasons why someone might want to use an IV formulation. On the other hand, if someone had problems with hypertension or if they were already a diabetic, this might be a little bit more difficult to give copanlisib because of the issues that have been seen. Although they can be successfully done with close follow-up and close monitoring. PI3 kinase inhibitors can be successfully given to the vast majority of patients, but we have to pay special attention to some of the adverse events associated with them. For instance, diarrhea. So diarrhea is a relatively common event across the different PI3 kinase inhibitors. There's basically two forms that occur. One that occurs with almost all the small molecules, and then there's a colitis or an inflammatory condition that can occur. So if someone has low-grade diarrhea, just a few bowel movements a day, then generally you can manage that with Imodium or low-middle anti-motility agents that that approach is successful. However, some patients get a much more of a colitis-like picture with watery diarrhea, and in that case we really have to stop the drug. The most successful approach is to recognize this early, hold the drug, allow for the colitis or this inflammatory diarrhea to resolve before reinstituting the PI3 kinase inhibitor. Sometimes we have to use oral non-absorbable steroids like budesonide to treat this in the way you might think of treating, say, someone with an inflammatory bowel disease to get that to quiet down. Very rarely does someone have to be given systemic steroids, but that should also be considered. Now, there are some other adverse events that we have to think about. So from the liver function test abnormality, it's important to monitor patients, especially on idelalisib and duvelisib, for the first 10 to 12 weeks. Generally, I would recommend monitoring LFTs every 2 weeks. If it gets, certainly if it gets to a grade 3 or a 4, you're going to want to hold that drug. I don't think if it gets close to grade 3, then you're probably better off holding the drug and not waiting for it to become a grade 3 or grade 4. You hold the drug, you wait for the LFTs to get to close to normal before reinstituting. Many patients can go back on at a normal dose and don't have reoccurrences. Some physicians prefer to decrease the dose one dose level, and that's also an acceptable approach. I think the biggest thing that we've learned from this class of drugs in general, and we have very good data with duvelisib, but I think this is also true with other PI3 kinase inhibitors, is that that we shouldn't be afraid to hold the medication. We shouldn't be afraid to dose reduce. We have data that shows that that with that approach, that patients benefit as much or maybe even better than those patients that you didn't dose reduce. So the outcomes are the same for patients who have the drug held or dose reduced as compared to those patients who did not. And that should give a lot of data and strength behind the recommendation to not be afraid to hold this medication. Now finally, copanlisib causes transient hyperglycemia and transient hypertension. For the vast majority of patients, there doesn't really need much to be done here at all. You, of course, want to monitor the blood pressure, you want to monitor the glucose, but by and large, if someone doesn't already have a problem with hypertension or someone doesn't already have a problems with diabetes, then little more needs to be done than observation. If someone is a diabetic or does have hypertension, then you may need to institute more aggressive measures such as careful monitoring, perhaps an insulin sliding scale, in order to get them treated. And finally, we should talk about prophylactic measures for infectious complications. These are potent inhibitors of lymphocytes, these molecules, and because of that, we worry about infectious complications. Many times we worry about some of the opportunistic infections such as pneumocystis pneumonia or cytomegalovirus infections. And so for PJP, I definitely would recommend that all patients be prophylaxed for this. For CMV, we just need to be aware that it occurs. In reality, the incidence is quite low, but it's not zero. There aren't very good ways of prophylaxing for cytomegalovirus. But what gets a lot less press is the common bacterial infections that occur. And while I don't think that we necessarily need to use prophylactic antibiotics unless someone's neutropenic in this patient population, this is by far the biggest infectious event that occurs. It's just the routine bacterial pneumonia rather than some of these other opportunistic infections, which are quite serious when they occur, but much rarer in number.